Dear colleagues, welcome to today's ESC webinar on the clinical presentation, diagnosis and treatment of myocarditis. This webinar has been made possible thanks to an unrestricted educational grant from Shire. My name is Perry Elliott. I come from University College in London and the Heart Centre at St Bartholomew's Hospital. And it's an enormous pleasure for me to introduce this webinar and the three experts who are here with us today. Dr. Alida Caforio, who is an expert in cardiac transplantation, myocarditis and heart failure from Padua in Italy. Dr. Karen Klingel, who is a cardiac pathologist from Tübingen University in Germany. And Dr. Renzo Marcolongo, who is also from Padua University and is a clinical immunologist. Myocarditis is a disease that presents at all ages and is caused by a wide range of pathogens, immune mechanisms, and various toxins and drugs. While myocarditis has been recognised as an entity for more than 100 years, its heterogeneous clinical presentation means that the diagnosis and treatment remains very challenging. In this webinar, we will focus on a number of aspects that we hope will help you to recognise myocarditis in your everyday clinical practice, whatever your background or specialty. Specifically, we aim to update you on the diagnosis of myocarditis according to new ESC task force criteria, to give you an overview on how to interpret the findings from endomyocardial biopsy, and show you how to apply the task force criteria in clinical practice using an interactive case. This session is designed to be highly interactive, and we strongly encourage you to participate by sending your questions and your comments at any time during the webinar using the chat function. We also encourage you to participate in the online MCQ towards the end of this evening's session. So it gives me great pleasure to introduce the first speaker, Alida Caforio from Padua. Alida, to give us, I think, a flavour for what the ESC guidelines now tell us about the diagnosis of myocarditis.
With great pleasure. Dear Perry, dear colleagues, good afternoon. Now, I have nothing to declare, and we will focus basically on this document that is a position statement from the working group on myocardial and pericardial disease, and is exclusively devoted to myocarditis. Now, in this statement, we give a definition that is in keeping with all major international, European, and classifications, as well as with the position statements. And basically, we say that myocarditis is an histological diagnosis. You have to find an inflammatory disease of the myocardium, and this is diagnosed by established histological features that are the Dallas criteria, but this must be completed by immunological and immunohistochemical criteria. And endomyocardial biopsy gives the possibility to distinguish different forms of myocarditis, mainly infectious from non-infectious immune-mediated forms. Now, why do we need a histological diagnosis? Because as clinicians, unfortunately, we have to say that there is not a typical clinical presentation of myocarditis, and as a matter of fact, myocarditis can give very mild cardiac symptoms and minor ECG abnormalities, as well as major ECG and arrhythmia changes, both brady or tachyarrhythmia, leading to even dramatic arrhythmia presentations such as syncope or aborted or even sudden cardiac death, as well as hemodynamic presentations such as cardiogenic shock of unexplained cause. And you can also have presentations with unexplained heart failure of acute or subacute chronic onset with or without a dilated phenotype, a dilated and dysfunctioning heart. And last but not least, you may have an infarct-like presentation with normal coronary arteries. Therefore, the task force criteria, well, the first requirement for defining a patient as a clinically suspected myocarditis, this patient must have at least one of these clinical presentations. It can be an acute coronary syndrome-like presentation with normal coronary arteries, and heart failure presentation, either new onset or subacute chronic. It may have an arrhythmia presentation or unexplained cardiogenic shock. But it is important to know that these presentations may be overlapping in some patients. So at least one clinical presentation, but this is not enough. In order to refine the clinical suspicion, you need also diagnostic criteria, and these diagnostic criteria have been put in different categories. The first category is electrocardiography in its various technical applications, from standard ECG to Holter monitoring or treadmill exercise testing. And you have to remember that myocarditis may give basically any ECG abnormality. You may have, this is the second category, may or may not have an increase in troponins without an underlying coronary syndrome or other causes of troponin release. Importantly, you may have morphofunctional abnormalities at cardiac imaging, both invasive and non-invasive. And this may be regional wall motion abnormalities, or global, and it may be just in the left ventricle or in the right ventricle or in both ventricles. And finally, you may also have a typical myocarditic type tissue pattern on cardiac MRI imaging. However, please notice that in the definition of clinically suspected myocarditis, you need the clinical presentation, one or more clinical presentation, one or more diagnostic criteria from the different categories I've shown you, and you have to exclude coronary artery disease as well as other possible causes that may explain the syndrome. And you may also have an asymptomatic patient, and in this case you need two or more diagnostic criteria from different categories. But then, if you want to achieve the diagnosis of certainty, you need to perform an endomyocardial biopsy. In this slide, there are also the so-called ancillary features. Well, ancillary features mean features that may or may not be present and are not necessary for the clinical suspicion. These include fever, as well as with or without an associated viral syndrome, as well as some peculiar findings in personal history or family history. This may be even more important. For instance, you have to ask the patient whether there are other immune-mediated disorders in his or her history or in the family, whether there is also a familial occurrence of dilated cardiomyopathy or myocarditis. And also, please remember that the peripartum period is a very important period that may be associated with an reactivation of immune-mediated disease. But then why should we aim at giving and having a definite diagnosis? Well, first of all, because we have many different causes for human myocarditis, and Professor Klingel will speak more about this. Mainly, there are infectious and non-infectious causes, as well as toxic causes. Now, non-infectious causes are generally treatable by by immunosuppression or immune modulation. But these drugs are contraindicated in infectious forms. Therefore, to have a differential diagnosis of the different forms of myocarditis, it is necessary to have an endomyocardial biopsy confirmation. Of course, you may have specific information in terms of the phase of the disease, acute, chronic, whether or not there are specific forms such as sarcoidosis or giant cell myocarditis, and is the only way to establish an infectious cause of the disease. Well, what is this important for the clinician? Well, we believe it is important and will change the clinical management. And this is, as a food of thought for you, this is an algorithm that is derived from the position paper on myocarditis, and we are very happy that the ACA from the ESC has taken this algorithm. And as you can see, once you have a definite diagnosis of myocarditis of non-infectious cause, and you have a hemodynamically unstable patient where you have used all available medical and as well as interventional as well as mechanical therapy, and in underlying giant cell myocarditis or sarcoidosis or eosinophilic myocarditis, immunosuppression is mandatory, and it may be also very useful in lymphocytic forms if there are no infectious agents. And having said that, I would like to thank you, and we are happy to take questions from the audience.
Thank you, Olivia. That's a very clear, I think, description of the new guidelines. I think perhaps many cardiologists are not familiar with this incredible spectrum of presentations of myocarditis. Are there particular diagnostic clues or red flags that you think should be highlighted for everyday practice?
Well, this is a very good question, and I would say from my clinical experience that if you have cardiac symptoms or signs of any type, from heart failure related to arrhythmia related, and in a young patient with an unexplained cause, then you should think of and suspect myocarditis, because in general this is a disease of the young. Of course, as you correctly pointed out, you may have myocarditis also in older people, but the majority of them are young. So this is definitely, I would say, a red flag.
So if we see AV block or ventricular tachycardia or new presentation of heart failure in someone at the age of 35, myocarditis should be fairly close to the top of the list of differential diagnoses.
Yes, provided that you exclude all possible other causes, of course. Yes, okay. Unexplained.
Now, obviously, we have a range of different presentations here, ranging from the pseudo-infarct presentation all the way through to fulminant heart failure. Do you think these different presentations have different natural histories or different outcomes?
Well, thank you again for this question. It's a very good one. And to be honest, I would say that we do not have enough data to be 100% sure of what the natural history of the disease is. In the few prospective studies of biopsy-proven disease, because it's very important that is biopsy proven, otherwise we are not sure about what is the diagnosis. If there is a deterioration of hemodynamic indices, both left and right indices, advanced NYHA class at presentation, this is definitely a marker of bad prognosis. Therefore, if you have a young patient with maybe a pseudo-infarct presentation and preserved ejection fraction, you may argue that this is a benign disease. Well, it is not exactly always the case, because if you use multivariable analysis, then you find out that the presentation per se is not an independent predictor. Of course, we need to have bigger data, even observational data, on well-characterized patients to better understand the natural history of the disease.
Okay. Just a couple of quick points, perhaps. One of the questions here is whether or not high-sensitivity troponin, whether we can make the diagnosis of myocarditis even if the troponin is normal. Is that consistent with the diagnosis?
Absolutely. I mean, and this is also a mystery in a way, because you may have patients with a severely depressed ejection fraction and no troponin release and biopsy-proven myocarditis. You may have, on the contrary, patients with a perfectly preserved left and right ventricular function and troponin release, unexplained troponin release, even for, let's say, several months, weeks or months, and in that case you have also biopsy-proven myocarditis.
Okay. There are quite a few questions coming in about differential diagnosis, and I sense already a slight nervousness about the requirement for endomyocardial biopsy. So perhaps if we can move to Karen to just show us how endomyocardial biopsy is so crucial to the diagnosis of this entity.
Thank you, Alida, dear Perry, dear Renzo. I have no disclosures. So, as Alida already said, the etiology of myocarditis is rather complex. On the one hand, we find infections, mainly infectious by viruses, enteroviruses, Coxsackie B viruses, are cytolytic viruses, which infect myocytes and they lyse them within 24 hours. We find adenoviruses, they play a role in children. Parvovirus B19 we find quite often, herpes viruses, human herpes virus 6, Epstein-Barr virus, and in immunosuppressed patients also human cytomegalovirus. Regarding the bacteria, we find Borrelia burgdorferi, inducing Lyme disease, especially in the southern part of Germany. And also importantly, we have Trypanosoma cruzi infections inducing Chagas disease, which is important in Southern America. On the other hand, we have immune reactions like in giant cell myocarditis, post-viral autoimmunity, drug hypersensitivity, rheumatic fever, lupus erythematosus, sarcoidosis, and so on, and cardiotoxic drugs. Now, the only way to differentiate all these entities of myocarditis is endomyocardial biopsy. And Gaetano Tiene nicely summarized the value of endomyocardial biopsies. So endomyocardial biopsy are the gold standard for the definite diagnosis of myocarditis, allograft rejection, storage disorders, and cardiac masses. It is essential in the differential diagnosis of the disease phenotypes, whether we have lymphocytic myocarditis or sarcoidosis or arrhythmogenic right ventricular cardiomyopathy, where we also have sometimes inflammation. So endomyocardial biopsies are required for the etiology-oriented therapy, and we need molecular analysis in order to get an optimal information on the etiology and the pathogenesis. And endomyocardial biopsies are used to define biomarkers to predict the prognosis of myocarditis. Now here you see what we are doing with the endomyocardial biopsies for the evaluation of the endopathogenesis of myocarditis and also of other cardiomyopathies. So we perform on paraffin-embedded tissue sections all of these investigations, histology, hematocylin eosin stain, maston trichome stain to evaluate the degree of fibrosis, special stains to exclude storage diseases, and electron microscopy, for instance, in Fabry disease. And of course, we are doing immunohistochemistry to define the cellular infiltrates and molecular biology for the diagnosis of virus bacterial infections in the heart. We're doing sequence analysis of the PCR products, the quantitative real-time PCR to evaluate the virus load, for instance, and in situ hybridization to localize the virus infections. And the Dallas criteria for myocarditis must be completed by immunohistochemical stainings to define the mononuclear infiltrates. And we have more than 14 cells, let's say CD3 positive T cells and macrophages per square millimeter to define myocarditis. And the positive immunohistology is an important predictor of the outcome in patients with suspected myocarditis, as was shown very nicely by Ingrid Kindermann and co-workers 2008. Here you see a typical picture of chronic myocarditis. On the left side, you see maston trichome staining. all the blue tissue reflects fibrosis, and you have in addition degenerated myocytes, but still CD3 positive T cells and CD8 positive macrophages expressing quite a lot of amount of MHC class II. Now, in addition, we are doing molecular diagnosis of cardiac virus infections, so the quantitative analysis of the virus load by PCR may represent the best way to verify the efficacy of the antiviral therapy and the viral clearance from the heart. In addition, we can do in situ hybridization, and this is the method of choice for demonstrating active virus replication directly in the tissue sections, and we can identify infected cell types, which is important for the pathogenesis of the disease. Here you see the prevalence of viral genomes in our patients with suspected myocarditis and dilated cardiomyopathy. And in more than 3,000 patients, you see that half of our patients are virus positive and half of our patients are virus negative. We mainly find parvovirus B19, human herpes virus 6, enteroviruses, and Epstein-Barr virus. And here you see an important slide demonstrating the localization of viral genomes in the heart by radioactive in situ hybridization. On the left side, you see Coxsackie virus infection. As I said, these are cytolytic viruses. They infect myocytes, they lyse them, and then the infiltrate follows and destroys the heart. On the other hand, you see parvovirus B19 infection. These viruses do not infect the myocytes, but only endothelial cells because of the receptor. And so you have complete different ethopathogenesis compared to Coxsackie virus infection. On the other hand, you see Epstein-Barr virus and herpes virus 6. These are herpes viruses, and they infect B cells or T cells. So what can we say about the therapy of infectious myocarditis? We know, for instance, that enteroviruses are susceptible to type 1 interferon. Herpes viruses, we have some drugs, ganciclovir, cytophobia, foscarnet, but so far we don't have any clinical studies which prove the efficacy of these kind of therapies. For bacteria, of course, we have antibiotics which work quite well. So we come to the non-infectious myocarditis. I just show you two pictures. Here on the left side, you see mesometricum stain in an eosinophilic myocarditis, and you see a severe destruction of the heart. Or the blue tissue is fibrosis. A lot of degenerated myocytes. On the right side, Giemsa stain represents the eosinophilic granulocytes, but you also have a few T cells and a lot of CD8 positive macrophages. And another disease, an autoimmune disease, is cardiac sarcoidosis. And here you see very nicely the granuloma destroying the heart. And we have no eosinophilic granulocytes in the Giemsa stain. This is in contrast, for instance, to giant cell myocarditis. But you have CD3 positive T cells and a lot of CD8 positive macrophages. And also the giant cells are CD8 positive. So how do we treat the non-infectious myocarditis? I don't say too much about that by immunosuppression because Renzo is talking about that later. And so I have a few take-home messages for you. And the endomyocardial biopsy is a safe, simple, and effective interventional procedure with a very low rate of morbidity and mortality. The endomyocardial biopsy is the gold standard for the diagnosis of acute and chronic myocarditis and must be performed by cardiopathological specialists. The Dallas criteria for myocarditis must be completed by immunohistochemical stainings. The molecular analysis is required to detect infectious agents in the heart. And endomyocardial biopsies reveal the etiology and nature of myocarditis, which finally determines the treatment of our patients regarding antiviral and immunosuppressive therapy.
Thank you, Karen. I think that's very clear. We're getting a lot of very good questions here. And I should just say that if we don't answer the questions during this presentation, we will be able to answer them offline later. There is a little bit of skepticism here, I think, about the value of endomyocardial biopsy in all possible cases of clinically suspected myocarditis. And perhaps that reflects people's real-life experience where often the reports they get are unhelpful or a negative when the clinical scenario is so strongly suggestive of myocarditis. Why do you think we see this mixed picture in real practice?
Yeah, this is true. The problem is actually that many clinicians send the endomyocardial biopsies to pathologists who are not trained in cardiopathology. And so finally they get a result of the biopsy, which is not really helpful. And this is really a problem, and we, of course, advised to tell people to send it really to cardiopathologists. If you imagine we are not doing anything else than cardiopathology, we get more than 2,000 patients a year all over Germany, Switzerland and Austria. And so we are really trained for many, many years to do the diagnosis, and you cannot expect that from all the pathologies all over the countries. That's a problem.
I mean, I think one of your most important slides was that complex investigation of an endomyocardial biopsy. It's not just simply about like microscopy, it's about electron microscopy, immunohistochemistry, PCR. What does immunohistochemistry bring? Does it increase the sensitivity of a biopsy, do you believe?
Definitely, definitely. You know, the Mason study many years ago had the problem. They didn't do that. They just had the Dallas criteria, and there was a lot of discussion about that. People said, okay, it's not worth to do that. Everybody says something else. And by the introduction of immunohistochemistry, it was clear which kind of infiltration we have just for the differentiation of sarcoidosis, of eosinophilic myocarditis, of lymphocytic myocarditis. This is really helpful and necessary. We cannot live without.
This is a question maybe for a leader. Quite a few comments are coming through here that if you have a typical presentation and a cardiac MRI which shows edema and unequivocal acute myocarditis, do you still need the biopsy? You have a clinical diagnosis.
Okay. I mean, you don't have a definite diagnosis of myocarditis without an endomyocardial biopsy. There are some scenarios where CMRI is more sensitive, and this is, generally speaking, the pseudo-infarct presentation with the normal coronary arteries and preserved ejection fraction. This is one scenario where CMRI is possibly more sensitive. However, it is not possible to be certain that indeed that is myocarditis, and you don't know what is the cause of that myocarditis. So if we don't understand what are the pathomechanisms that are behind the resolution of an acute phase versus relapse or, let's say, chronic dysfunction, we have, selection bias. What I can say is that definitely CMRI is not that sensitive in arrhythmia presentation and in heart failure presentation, and that even in a pseudo-infarct presentation, especially if troponin release is not that high, or let's say sustained over weeks or months, CMRI may not tell you the truth, and we have patients actually that apply this to this particular scenario. Plus, as I say, I mean, if we want to have a whole scenario of natural history of the disease, we do not need to create selection bias.
Okay. There's been a bit of a reaction to parvovirus.
I can imagine.
I think it was more than a third of people in that series that you showed had evidence of parvovirus causing myocarditis. Do you want to expand on this? It's a bit curious, isn't it? It's an endothelial pathogen. We find it in low copy number in normal individuals. Is parvovirus really important?
It's a very good question and a very difficult question. We know that parvovirus B19 can definitely kill people. We have quite a few kids at the age of 2 or 3. They really died due to a severe parvovirus B19 myocarditis. We also have an adult patient at the age of 33. She was admitted to a hospital with myocardial infarction, and it turned out that she had a severe lethal parvovirus B19 myocarditis. But what I have to say, you find, of course, in many patients, a few hundred copies, let's say. And the problem with parvovirus B19 is that it is a persistent infection. We do not know actually whether we can get rid of that infection because it's all over the body. We have a bioportfolio by parvovirus B19. It's in the synovia. It's all over the body. And so we do not exactly know how to deal with the patients. But the main thing is not exactly the parvovirus, but the inflammation. If you have inflammation in addition to several thousand copies of parvovirus B19, and we can prove that also by inside hybridization, that it infects endothelial cells, then it's relevant. And the relevant thing is really the inflammation. And the parvovirus B19 can induce apoptosis and can also affect via cytokines, for instance. So we can have a kind of inflammation which comes due to the parvovirus B19 infection, but this is not the case in all of our positive patients.
So one of the implications of what you're saying, I think, is that another layer of complexity to the analysis of a biopsy is the measurement of copy number. It's measuring
copy
mRNA.
number, definitely, yeah. We had this paper in New England Journal of Medicine demonstrating we had a cut of 500 viral copies. And so we have always several hundred copies, thousands of copies in association with inflammation. If you have only 100 viral copies, you usually do not see any inflammation.
Okay. So we might be winning a few of the doubters over. There's still a few here on the screen.
I can imagine.
So perhaps we can try and persuade them by moving to the case, perhaps, which illustrates some of the real-world dilemmas, I think, of this entity.
With pleasure, with pleasure. So this is, I have nothing to disclose in relation also to this presentation. This is a case of a young, middle-aged adult, 47-year-old man, smoker, with a family history of myocardial infarction and as well as nothing else. Very active, skipper. In November 2013, he starts complaining about dyspnea, worsening dyspnea, even paroxysmal nocturnal dyspnea. So he undergoes a cardiological assessment, and the first echo he does as an ambulatory patient reveals a dilated cardiomyopathy with a very severely depressed ejection fraction. So he is admitted to hospital for further investigation, and he's admitted to our institution, and of course we start first of all to stabilize the patient clinically with IV diuretics as inhibitors and with a slow introduction of carvedilol, low dose. Then we perform an echo after a week or so of hospital admission, and there is not much of an improvement, as you will see afterwards. From the ECG point of view, this is his ECG after introduction of medical therapy, and he's not any longer tachycardic as he was at the beginning. There are repolarization abnormalities that are not so specific. Actually, the patient also complains of some sort of chest discomfort, even with a light exercise. And he is not hypertensive. And this is the first echo. After 1 week admission at our hospital, and you will see that there is a very bad left and right ventricular function with global hypokinesis and functional MR. And here the same is also on a 3D echo. We performed also a contrast echo because, as you will see afterwards on CMRI, there was suspicion of a thrombus in the left, in the apex of the left ventricle, and there is also moderate to severe tricuspid regurgitation. So, severe, recent onset, dilated cardiomyopathy with biventricular involvement. Now, that's my question for the audience. Clearly, we are in a webinar on myocarditis. So, but I would very much like to see what really the audience would do in the real world. So, option A could be perform a CMRI, and if there is not an ischemic pattern, having a sort of conservative approach with medical therapy and of course putting a backup ICD. Option B would be more aggressive, complete cardiac cath to exclude coronary artery disease, medical therapy, an ICD of course, backup ICD, and then a transplant checklist. And then option C, cardiac catheterization and coronary angiography, and if normal coronaries, an endomyocardial biopsy. And if regarding, the findings on endomyocardial biopsy, actually the further diagnostic workup and as well as the timing of ICD implantation could be different.
Thank you. So the audience is just voting on that now. This is not such an unusual presentation, is it? I mean, if anybody who works in a busy heart failure practice will probably see many patients like this. So again, what are the red flags here, do you think?
Well, red flags, not many actually, because yes, there is a recent onset heart failure presentation. But there are no other red flags at all. Actually, there are red herrings because the patient is a smoker, family history of coronary artery disease, chest discomfort, as well as dyspnea. So this might well be even triple vessel coronary artery disease. There are no...
So we don't know unless we do the right investigation?
I think so, yeah.
So, despite the comments from some of the earlier audience members, I think it's very interesting results, I think. So we have 7% who go for option A, so they would have done an MRI and then medical therapy and a defibrillator. 16% would do catheterization, coronary angiography to exclude coronary vessel disease, as you described, would then put in an ICD if it was non-ischemic, with medical therapy and a transplant workup. But 76% went for option C. So,
great.
You've made my colleagues here very happy here.
Either there is a selection bias in the audience of this webinar, but I'm very happy to show you the follow-up of this case. Now, clearly, we are a transplant center, so and in general we have a thoroughly pre-transplant workup in a young patient before considering checklist. Of course, first thing is cardiac catheterization, and as you can see here, there are normal coronary arteries and a very bad left ventricle. Second thing we did, of course, an MRI, and of interest also the MRI done at the same time of a complete cardiac cath shows is very much in keeping with both the echo and ventriculography. There is a very bad biventricular dilated cardiomyopathy. And in relation to the tissue characterization, it is of interest that there is only a focal epicardial spot of late gadolinium enhancement here. And there was evidence of the thrombus. That's why we also put the patient on warfarin. But there is no edema, and actually the response from the MRI was that this is non-ischemic dilated cardiomyopathy with severe biventricular dysfunction. No mention about possible myocarditis or even post-myocarditis DCM. Sometimes you get this sort of results. This is the endomyocardial biopsy showing active lymphocytic myocarditis, focal in distribution, with negative screening for all cardiotropic viruses. So, in relation to solution of the case, we went for basically option C. We sort of went further on.
Maybe if I can just interrupt
Yeah.
you just to pick up on
Yes.
it, because I think there's a number of really important practice points here. So,
Yeah.
with regard to MRI, this is sort of the reverse of the discussion we had earlier. So you very clearly said that there may be circumstances where MRI may be a more sensitive test,
Yes.
such as pseudo-infarct pattern.
Yes.
But here we have a patient who has clear cellular infiltration with no evidence for myocarditis on biopsy. So, Karen, as a cardiac pathologist, does that ring true to you?
On CMRI.
On the MRI, sorry. So no edema on the MRI,
Yes.
and yet you have a lymphocytic infiltration. So what's going on there?
That fits very well. We always see that. Well, we often have patients with edema or the other way around, and infiltration. And so as a cardiopathologist, we cannot really relate on that edema. What we do as a diagnosis of myocarditis, of course, degenerated myocytes, necrotic myocytes, and cells, as you said. The inflammation is the diagnosis of myocarditis. And edema is not the only disease for myocarditis.
So I'm being told here that the MRI has not been done properly, but I think, but this is a very important point, isn't
Yeah.
it? Myocarditis is a cellular infiltrate.
It is.
That's
is.
what defines myocarditis.
Right.
It's not
Right.
defined
Nothing
by
else,
edema.
no edema, no, definitely no.
Okay.
Well, anyway, this in terms of MRI, this is a very multi-center, let's say, evidence now that in the heart failure presentation, in the sort of DCM-like presentation, MRI, even in the best hands, is not as sensitive as endomyocardial biopsy. It is more sensitive for unknown reasons so far in the pseudo-infarct presentation. Mm-hmm. And we have the same experience also at our center.
Okay. Can I say, looking for red flags, do you think the presence of thrombus tells you anything? Or?
Well, one would may think of hypereosinophilic myocarditis, but there are no other red flags here. There is no hypereosinophilia. There were no other, let's say, clinical associated conditions for secondary hypereosinophilia. So I think in this case, thrombus was just the expression of an inflamed heart with a severely depressed ejection fraction. And as a matter of fact, as you will see afterwards, when the patient was cured, the thrombus disappeared. And
so perhaps we should see how this case resolved itself.
Yeah. Well, first of all, we thought about an ICD implant, but likely we had the possibility to have a life vest in this patient, and on the basis of the endomyocardial biopsy and with the decision of having an immunosuppression treatment started in this patient.
So this is really important, isn't it? Because
Yes.
the rationale here is that you have a potentially recoverable heart.
Exactly. And in fact, we started, this is, according to task force criteria, it's a lymphocytic myocarditis that is clearly not refractory to standard therapy. This patient was, almost in sort of checklist window. So we decided to postpone the ICD implantation to have a life vest instead and to start immunosuppression. And we started with steroids and with azathioprine according to both the thymic trial and the myocarditis treatment trial arms. And But we did it for not just for 6 months, and Renzo will talk more about tailored immunosuppression. But also, I mean, as cardiologists, we are a little bit naive in terms of how immunosuppression should be handled. And we think that 6 months is enough, but as a matter of fact, autoimmune diseases are cured, need immunosuppression for years. In this case, we went on with the 16 months immunosuppression, and finally we got a full recovery of left and right ejection fraction. We managed to take off life vest, that is not very comfortable for the patient, to taper of immunosuppression, stop warfarin. However, still now, the patient is still on low dose azathioprine, and the endomyocardial biopsy is scheduled for to have guidance in terms of when to stop. This is the echo, the last follow-up, and you can appreciate that it has been a full recovery of left and right ventricular function. And this is the MRI, very much in keeping. We have the same parameters also on MRI, with no more even the small focus of late gadolinium enhancement that was detected in the diagnostic MRI, and no thrombus. And so this would be our take-home message. Thank you.
Okay, thank you very much. Quite a lot of questions coming in about, do we really need to biopsy every patient with suspected myocarditis, and in particular, the question of dilated cardiomyopathy?
Oh, yes.
So very sort of brief answer if possible.
Yes,
yeah.
Dilated cardiomyopathy is, I think, unethical not to have an endomyocardial biopsy. Yes, especially if we want to exclude, to rule out, or to rule in inflammatory cardiomyopathy, you need an endomyocardial biopsy. And we are starting to see the tip of an iceberg. We are doing at our institution prospectively immunosuppression in inflammatory cardiomyopathy without contraindications, without viruses, with very, very promising results, very much in keeping with, for instance, the published data. Yeah.
So we moved to immunosuppression, something that perhaps most cardiologists are not familiar with, Renzo, so educate us.
Yes, thank you very much. Good evening, and thank you for your kind invitation to this webinar. I am an immunologist and also a cardiologist, and I have the pleasure and the privilege to work with Alida Caforio at Padua University Hospital in the treatment of patients suffering from autoimmune myocarditis. In these last few minutes, I would like to address some elementary point about the controversial topic of immunosuppressive therapy of autoimmune myocarditis. I'm nothing to disclose. And, everybody knows that immunosuppressive therapy is an essential, very important resource for the treatment of many systemic and organ-specific autoimmune diseases. We can define immunosuppression as a controlled inhibition of host immune reactivity obtained by a pharmacological and or physical tools induced to prevent or to suppress pathogenic immunological reaction in organ and tissues. We have plenty of possibility to treat every patient in a tailored and personalized manner, and we have plenty of possible combination to face every even difficult clinical condition, provided that we have a flexible attitude to treat every patient, adapting and personalizing the approach, the dosage of the treatment to optimize the action of immunosuppressive therapy and to minimize adverse effect. But why should we treat with immunosuppressive agents a patient with autoimmune myocarditis? As in ischemic heart disease, you know that also for myocarditis, time is muscle. So as soon we start in well-defined case the treatment, the better will be the result in terms of tissue recovery and pump function recovery. But also in cases where the pump is good, we have to consider the arrhythmia risk, and immunosuppressive therapy can do the difference in this patient, reducing the occurrence of fatal arrhythmia. Of course, also in our hands, immunosuppressive therapy was able to prevent the recurrence of the disease in the heart. But when should we treat a patient in total safety? Because the safety is a very important issue dealing with immunosuppressive therapy, no matter which is the disease, because we have to reduce the function of a vital system of defense like immune system. Well, for myocarditis, we have to rule out for sure every evidence of infectious etiology. So I fully agree with my colleagues about the value of endomyocardial biopsy. It is, we cannot do without endomyocardial biopsy to treat a patient with immunosuppressive therapy. No discussion, in my opinion, but it is just my opinion. Of course, we have to exclude systemic organ and systemic contraindication to immunosuppressive therapy, including, of course, latent infection of other nature, latent malignancies, but also it is very important the psychological condition, the fully mindful consent and collaboration of the patient, who should be motivated and active in this teamwork, which is immunosuppressive therapy. Of course, the results of the treatment with immunosuppressive therapy of lymphocytic myocarditis has been studied with the trials, myocardial treatment trials of 1995, and the TIMIC trial, the more recent TIMIC trial 209, with contradictory results. In every case, these trials are limited to azathioprine, which is usually very safe and very easy to use, and cyclosporine, along with corticosteroids, prednisone, that we have to say are not usually a serious risk for the patient beyond water retention or glycemic control, that it is usually easy to achieve. But our knowledge is limited to this medication. If we take in consideration, for instance, other specific form of myocarditis, such as eosinophilic myocarditis, giant cell myocarditis, sarcoidotic myocarditis, and so on, we should enlarge our skyline to other medications, such as mycophenolate, mofetil, very useful in our experience in SLE-associated myocarditis, and so on. And what about biologic agents? There are only sporadic or anecdotal experience, but is another field to explore in this, with this purpose. Of course, as I told you before, there are controversial point of view, but we can address well-defined questions about this controversy. For instance, which is the right medication? Which is the optimal dosage? When should it be started? Very important, because usually in the trials, in the above-mentioned trials, therapy has been started after 6 months or 2 years after the onset of the disease. Maybe too late if time is muscle. Okay? Another very important point to address is how long should we continue? Because in our experience, and not only in our experience, using azathioprine for only 6 months is not enough, because it is a medication that usually takes the field very slowly and takes at least from 1 to 3 months to start to work hardly. So 6 months can be too short. Better to prolong the treatment. In our experience, with more or less 40 patients, a prolonged treatment with this medication seems to produce good effects. But there are also many other points that there is no time to discuss. To conclude, which are the mainstays of immunosuppressive therapy in autoimmune myocarditis? First, endomyocardial biopsy. We have definitely to rule out infection and to establish a well-defined diagnosis. Second, a continuous interprofessional teamwork between the cardiologists, the pathologists, the immunologists, the expert of immunosuppressive therapy, but above all, with the patient, which is the best partner during a long treatment with immunosuppressive medication to reduce the risk and to optimize results. That's all, in my opinion.
Again, the message is that it's complicated. It's not just about steroids, and it's about a long-term therapy in many patients. It's not just a simple pulse of therapy and then you hope that everything goes away.
Yes, don't be afraid of steroids. Of course, we have to check out the patient with the help of the patient himself. But remember that steroid plays their role mainly at the beginning. Then you can quickly taper down them and to continue with the immunosuppressive drug, the main immunosuppressive drug, it is to say azathioprine or cyclosporine or mycophenolate. Usually, as to the azathioprine, it is a very safe, well-tolerated medication, even for prolonged period. So don't be afraid.
And a question for both you and Alida. What are your markers of response? So how do you monitor these patients during immunosuppression?
Well, we generally perform serial ECG and echocardiography, mainly echocardiography as a marker of recovery of ventricular function, and then of course as a sort of arrhythmia burden. Depending on the kind of patient, we may have frequent Holter monitoring or even loop recorders in a few patients where being very long-standing disease or even patients with a recurrence, we have implanted loop recorders, and it is really promising how according to the immunosuppressive response, you get rid also of the arrhythmia or reduce the arrhythmia. For now, you just have very simple measures, arrhythmia burden and recovery of ventricular function.
But again, it illustrates the point.
And troponin.
Yeah.
Because there are some, when the patients with the troponin release are in a way the lucky few, because you have a clear marker of myocardial damage.
So, if the case, not in all patients.
Not in all patients. In our experience, troponin release responds very well to immunosuppression. It's a very good marker.
You can observe the dramatic reduction.
Yes.
Okay, and the implication of all
in
this...
in the end, when we have to decide when to stop, again, we may have intermediate MRIs if there is no ICD, but then endomyocardial biopsy.
But the implication, I think, which comes out in the ESC document is that these patients need to be followed in a systematic way.
Absolutely.
During immunosuppression and following tapering and discontinuation.
Absolutely.
Yes.
Dedicated outpatient clinics.
Okay.
Yes.
So I think we're approaching the end of the webinar. I'd like to thank all my colleagues for a really stimulating discussion. I think we've learnt that myocarditis is a very complex syndrome with many different presentations that could appear to cardiologists of whatever their subspecialty. However, I think that complexity we've also learnt can be managed if one has a high index of suspicion for the condition, and perhaps even more importantly, that one works as a multidisciplinary team, which involves not only cardiologists, but pathologists, immunologists, and as Renzo has said several times, the patient themselves. We'd like to thank you for your participation. I think your questions have actually been fantastic, and as I say, we will respond to these after this webinar. So from Nice this evening, good evening.